We're excited here to have with us Dr. Denise Goodwin. She is, among her many talents, she is a coordinator of our neuro clinic in Hillsborough and the founding editor of our digital quarterly Opacities newsletter. So without further ado, please welcome Dr. Denise Goodwin with her presentation of unexplained vision loss, and where do I go from here?
All right. And I appreciate the committee inviting me to do this lecture. I think it's a pretty important lecture because there's a lot of times when, it's just really difficult. We have these patients and they have vision loss, but everything looks normal. And so, but it can be really rewarding too to be able to figure out what's going on with these patients. And sometimes we can even end up saving their vision and their lives by continuing to figure out what's happening. So I have no disclosures, and hopefully by the end of this lecture, if nothing else, that I'll convince you that it's critical not to ignore even the smallest amount of vision loss. So even if a patient sees only 20/25, that we continue to figure out what's going on. So we'll discuss the importance of a methodical case history and the tests needed to localize the cause of the vision loss, and then we'll go over some causes of vision loss. So there are many causes of vision loss, making the diagnose somewhat difficult, but the value of a case history, as with most things, can't be really overstated. It helps us to come up with some differential diagnoses as well as lead us down the proper path so that we can choose proper ancillary testing. So defining the duration is pretty critical in the history of these patients. So recent vision loss should be evaluated fairly emergently. Generally, as a general rule, you can think that however long the vision loss has been going on, that's about how long you have to get the patient in. So if they said their vision loss was 3 months ago, it's probably not that emergent. But if they came in and they said, my vision loss was 3 hours ago, then we probably need to get them in pretty quickly. Of course, sometimes sudden vision loss isn't always sudden, but the patient rather noticed it suddenly, and that's the case with this person here that's shown in these images. I'll use the mouse so that, assuming I can find it here, so that you can see it on both sides. This person has a little bit of pallor. They actually came in after they had noticed some vision loss after they had a massage. So they were face down, pushing their eyes, they looked up, and they noticed this sudden vision loss. Okay, but due to laboratory testing, we actually found out this was a congenital optic neuropathy, and so the patient just happened to notice it emergently, and sometimes that can complicate things as well. So determining the laterality can help. Of course, if anything is in front of the chiasm, we want to be thinking about the eyeballs. If anything is in front of the chiasm, it's going to probably be causing monocular vision loss, with some exceptions that we'll talk about. If it's behind the chiasm or at the chiasm, then we need to start thinking about vision loss in both eyes on the same side, so like a homonymous hemianopia. The timing can be pretty critical. This table lists some of the timing characteristics, and if you send me an email, or maybe I can put something in box with if you want these handouts, so you don't have to write all of this down if you're interested. But if the patient is experiencing vision loss that's just lasting seconds, we should be thinking about something like the tears causing the problem, or intracranial pressure. Increased intracranial pressure can also cause intermittent vision loss of seconds. If it's lasting 1 to 10 minutes, thinking about an vascular perfusion issues is probably more appropriate. And with orbital tumors, one thing to keep in mind is that you can have intermittent visual field loss with gaze changes. So if you look off to one side, then the vascular perfusion is cut off to the optic nerve and you lose vision. And then they look back forward and the perfusion comes back, so the vision comes back. So kind of keep that one in mind as well. Of course, migraines can result in vision loss lasting 20, probably up to 60 minutes. And optic neuritis usually lasts about 6 weeks. Associated symptoms can be pretty important. If we're dealing with, a red, painful eye, of course, that's going to lead us to think about maybe something more in the anterior segment that's causing the vision loss. But if we have the patient with numbness or impaired speech or memory, then we'll be thinking more about a neurologic cause. Ocular history can be important, particularly ruling out any amblyopia or hereditary disease, and systemic illnesses or medications are important as well. These are some of the more common medications that can result in vision loss. So we can get uveitis, we can get cataracts, we can get maculopathy. I won't go over all of these. I found this one kind of interesting, canthaxanthine. It's a oral agent that you can take to get a tan. And I got these pictures off of their advertisement, and apparently it also gives you ab muscles as well. So, but it can cause some macular edema. And one way commonly used, also cholesterol-lowering drugs can cause macular edema. So kind of keep those in mind. Some of them are quite common. Again, there's a number that can cause optic neuropathies as well. And again, if you want a list of these, I'm happy to send you the handout so you'll have these just as a resource. And so if you have somebody with unexplained vision loss, at least pull a list out and look at it to see if there's one of the medications on the list. Once we have a tentative diagnosis based on the history, then we move on to the examination. After determining the actual acuity level, we want to assure that the visual acuity loss isn't just refractive. Of course, the most simple way and efficient way of doing this is with pinhole acuities. Do keep in mind, though, that like irregular astigmatism due to a corneal or lens abnormality will improve with pinhole acuities as well. Contrast sensitivity can be very helpful in diagnosing patients that feel like they have vision loss, but they have normal acuities. So contrast allows a processing of visual scenes, and so these people might have problems recognizing faces or driving despite having normal acuities. Another helpful thing with if you have a neutral density bar is it helps to differentiate between optic neuropathies and amblyopia. So if you have a patient with amblyopia and you change their contrast, essentially this is a contrast sensitivity test as well, we change their contrast by putting a neutral density filter in the eye, the acuity should not drop with amblyopia. But with an optic neuropathy, the acuity will drop drastically with changes in contrast sensitivity. Color vision, very helpful, whether it be pseudoisochromatic plates or a red cap test. And one of the most critical tests that we have really is pupils. And that really can help us differentiate the location of the vision loss. Carefully look for subtle corneal edema or maybe just mild anterior chamber reaction. But as you start to look at the eye, notice if your view in is the same as what you would expect with their view out. So if you have a patient that's seeing 20/40, but you have a really crystal clear, nice 20/20 view of the optic nerve, then you're probably not dealing with the media as being the cause of the vision loss. In this case was one that we could have easily blamed on cataracts. He was a 64-year-old male and had just very slightly decreased acuities in that right eye. He was 20/25 in the right and 20/20 in the left. And we'd seen him every year for many years, and he'd always been 20/20. He was here with really no complaints. He was diabetic, but he had absolutely no complaints. He was just here for his annual exam. So based on the decreased acuities, I had the intern go in and I said, well, go and see if you feel like the cataracts are bad enough that you would cause this. And he came back and he says, yeah, I really don't think that the cataracts were bad enough that it would cause this 20/25. So we started doing other tests, okay. He didn't notice that color vision was down, but the pseudo-isochromatic plates were actually 9 out of 17 in that involved eye. He did not have a relative afferent pupillary defect, and the ocular health was normal. He had no diabetic retinopathy, as you can see here. But due to the decreased acuities, we did a visual field, and he did have mild visual field loss in the other eye as well. So he had a little bit of visual field loss in the left eye, but pretty considerable amount of visual field loss in the right eye, the involved eye. The OCT of the peripapillary nerve fiber layer was unremarkable, but you can see with the macular OCT that we have some thinning. And it's hard to even tell what layers are really causing the thinning when you look at the cross-section of the retina. So because of that, we ended up doing a multifocal ERG. And here, left eye shows nice pastel colors, which is what we want. That's normal. But you can see that he has bright or dark red colors on the multifocal ERG, meaning that he has pretty significantly decreased retinal function in that right eye. So this not only told us that the retina was the problem, but it told us that either the cones or the bipolar cells, the outer retina, was what was causing the issues. So that narrows down our list of differentials pretty significantly. So when we started, we went through then our differentials, and we started talking to the patient, asking him a few more questions at this point. And he mentioned then that he had had multiple skin and mouth cancers removed, both basal and squamous cell carcinomas, including one particularly invasive carcinoma, squamous cell carcinoma 11 years earlier, that he had to have his nose totally reconstructed. So because of that, we ended up sending him for laboratory tests to look for cancer-associated retinopathy, and sure enough, he did end up having paraneoplastic antibodies. Okay, and so then you want to be looking for cancer other places in the body. So in this case, it turned out it was pretty important that we didn't just assume that this 20/25 vision was just the cataracts. Now, most of the problems that are severe enough to cause vision loss are going to be visible on the examination. But as we all know, a normal eye exam does not rule out pathology. So it's important that we continue to look, or at least refer somebody to refer them to somebody who can continue to look. So in addition to our basic exam techniques, other tests can be very helpful. If the ocular health looks normal, I found that topography can be very helpful, picking up subtle corneal irregularities or even tear deficiencies that could be causing problems with the decreased visual acuity. The photo stress test, this is quite helpful in diagnosing retinal conditions. So just like trouble recovering from bright lights or recovering from dark lights, this can indicate that the photoreceptors are not regenerating properly. And so that's what this photo stress recovery test does. And one of the most dramatic examples of this was actually a patient that I kind of found on accident after doing a fundus exam. I wasn't purposefully doing a photo stress recovery test, but I did my high plus, and then I get done, and the patient starts to complain more vociferously than most. So they all complain, oh, that was a really bright light, I can't see, right? But they were pretty adamant that they were unable to see. So we took acuities, and now she was 2200, which she was probably only 2025 before high plus. And it actually took her 20 minutes before we got her back down to her pre-bright light acuity. Okay, so because of that, as well as a couple other signs that we had seen, we ended up sending her for a carotid artery ultrasound and found that she had really significant internal carotid artery occlusion, indicating ocular ischemic syndrome. Okay, so again, keep some of the simple tests in mind as well. OCT can be very helpful in differentiating some retinal conditions. These patients were both referred to us for unexplained vision loss. This patient here on the left has very normal retina. Even once you see the OCT, there's nothing you're going to see on the retina. But you can see with the OCT that he does have some very subtle macular edema causing the 20/30 vision loss. This one had 20/70, and I think you can appreciate a little bit of edema, a little bit wider there, and it gets a little darker there. They're hard to see, but still there. But definitely once you look with OCT, you can definitely make the diagnosis very easily of a macular hole. So these conditions, as well as an epiretinal membrane, choroidal folds, sometimes even central serous, can be very difficult to see with a fundus exam, but made very obvious with OCT. This was actually one that was kind of an interesting one that we found with OCT. Very subtle, but this young lady came to us with a spot. She reported just a spot in her right eye. And she'd seen a couple of specialists and been told many times in her life that there was nothing wrong, everything was normal. And her vision was only slightly down. It's 20/20 minus 1 in the right eye versus 20/20 in the other eye. But with OCT, we can see the reason for her symptoms. So other than the fact that this is monocular, this is pretty typical appearance for solar retinopathy. So again, then we start asking her, some more questions. She says, well, they may have shined my brothers may have shined a laser in my eyes when I was younger, but she did actually admit that she did like to look at the sun. Okay, so although there was nothing we can do about this at this point, it's important that we found this. First of all, the patient was very grateful that we at least told her she wasn't making this up, because everybody else, she knew this was there, and she was just frustrated that nobody could find what was going on. But also, it was really critical that we educate her not to look at the sun, okay? So, electrodiagnostics, invaluable in patients with unexplained vision loss, and it can also help in ruling out functional vision loss as well as differentiating retinal disease from intracranial pathology. These images were from a 30-year-old white female, and she was having hazy vision in her right eye. She was seeing 20/20 in both eyes, but it just wasn't quite right in that right eye. You can see fundus look totally normal, and there is a slight visual field defect on that right eye that she's not seeing as well. But here the VEP, the visual evoked potential, was what really helped us make the diagnosis. And you can see this shows a delayed response. So the left eye is in purple and the right eye is in red. So you have a delayed response of the right eye at various stimulus sizes. And this ultimately led us to a diagnosis of optic neuritis. And she was then subsequently diagnosed with MS, and is now on treatment for MS. Autofluorescent imaging, also very helpful in differentiating some of these difficult cases. These are visual fields from a 26-year-old female. She was referred to us to rule out an aneurysm because of these binasal visual field defects. The patient was asymptomatic, and they were 20/20 in each eye. They just had this visual loss on the visual field. You can see that there is some subtle pallor inferiorly, which lines up with the superior visual field defect. But once we take an autofluorescent photo, you can see that she has optic nerve drusen, most evident inferiorly, which is causing the superior visual field defect. So in this case, the autofluorescence saved this patient thousands of dollars in neuroimaging, trying to figure out why her visual loss was there. So it definitely saved her a lot of time and money. So let's talk about some potential causes, some things that we should have on our list of differentials. The etiology of vision loss can be broken down into 4 main categories: media opacities, retinal abnormalities, neurologic disease, and functional disorders. Now, I do want to say a word about amblyopia. Technically, I would put this into a neurologic condition because it is a brain problem, but it's definitely one of the differentials that we consider with every single person that we see with unexplained vision loss. Also, keep in mind that one of the biggest lawsuits in the history of eye care came from an ophthalmologist who had misdiagnosed a tumor and called it amblyopia. Okay, so before making the diagnosis of amblyopia, make sure that we have a reason for the amblyopia. Do they have strabismus, or have they had a history of vision therapy? Do they have a large refractive error or anisometropia? There has to be something there as a reason for the amblyopia before making that diagnosis. Old records can be very helpful, making sure we've got a fairly stable visual acuity. And don't hesitate to run a visual field if you do question the diagnosis. Most anterior side conditions are significant enough that you can see the cause of vision loss, but some are still subtle. If you are thinking that it might be a media problem, again, one of your most helpful tests here is a pupillary test. We're looking for a relative afferent pupillary defect. You will not get a relative afferent pupillary defect from a media opacity. Okay, even like a 3+ cataract, you're not going to get a relative afferent pupillary defect. Also, again, as I mentioned, just make sure that the visual acuity in makes sense with the visual acuity out. Okay, otherwise keep looking for another cause. Vitreous hemorrhage can be a cause, and hopefully we don't miss a relatively large vitreous hemorrhage. But sometimes they can be difficult to pick up. This patient actually was a 47-year-old gentleman, and he was referred to our neuro-ophthalmic disease clinic due to decreased vision in both eyes. And he had been previously seen by a retinal specialist who reported everything is normal, and a cataract surgery center who said it wasn't cataracts causing the problem. And so, and I mention that to show how difficult some of these cases can be. They're not always straightforward. Acuities in the right eye were 20/25, acuities in the left eye 20/30, and appropriately, the referring doctor didn't just stop because the retinal specialist and the cataract specialist said it's not them. Okay, they kept looking. So as you can see, we've got maybe a mildly blurry view in this eye, the right eye, but you've got a pretty significantly blurry view in the left eye, indicating that we have some sort of a media opacity. The patient did not have a relative afferent pupillary defect. Visual field defects, you can see, are central in both eyes. And OCT found borderline thinning in the right eye, perimacularly, left eye totally normal. And so with all of this information put together, my first thought would be we're dealing with cataracts, but it wasn't. The cataracts did not look bad enough to cause this type of appearance. But it ended up that this person actually had a really significant vitreous opacity that was quite anterior. And that's why you can't see it even in these cross sections. But when we were running the OCT, we saw this huge vitreous opacity kind of coming up and down. So sometimes it pays to run your own OCTs as well, because you find stuff like that. One of the more emergent causes of transient vision loss specifically is a vascular insufficiency. And this is generally going to be monocular, either with partial or complete loss of vision lasting from 1 to 10 minutes. Most commonly caused by problems with either the carotid artery or the heart. And this is pretty critical to recognize because patients who experience amaurosis fugax are at an increased risk of an ischemic stroke. So this is a 54-year-old asymptomatic patient, and he was told that he had an episode of optic neuritis in the left eye 8 years previous. Acuities in both eyes were 20/20, and we were able to obtain his old photos, which look more like non-arteritic ischemic optic neuropathy versus optic neuritis, but at this point, not a huge issue. The disc edema you can see is worse superiorly, which accounts for the pallor that is superior and the inferior visual field loss in the left eye. But the question is what is going on in that right eye that's causing this loss? Okay, we look at the OCT, and that actually matches up pretty well. We've got some neurofiber layer loss matching up with the visual field. We decided to do a multifocal ERG, and again, you can see left eye fairly normal, but the right eye, we've got this pretty discrete area here of decreased retinal function. And so this again is telling us that it's the outer retina that's causing the problems, and we can start kind of looking a little bit closer in that area. So when we went back and looked really closely, you can actually see that they actually did have a little plaque in the artery there. So we did end up sending this patient for a cardiologist, or to a cardiologist for an EKG and carotid ultrasound in this case. Various maculopathies are going to result in vision loss, and a lot of times these will be very subtle. It can be, here the OCT really is going to be invaluable. The absence of a relative afferent pupillary defect are going to help us differentiate these from neurologic causes. And generally with macular edema, particularly of central serous or cystoid macular edema, most of these patients are going to come in reporting metamorphopsia. So they're going to say that things are wavy in their vision. Most of the time, these retinal conditions are monocular, but some do present bilaterally. Macular dystrophies have a bilateral progressive vision loss. Toxic and nutritional retinopathies, again, will be bilateral. And electrodiagnostics can be particularly helpful in diagnosing these retinal disorders as well. Any disease that affects the optic nerve can result in vision loss. Papilledema will cause transient visual obscurations, but this is going to generally be pretty obvious when you're looking at the fundus exam, unless it's chronic. Sometimes you can get chronic papilledema, and then we get reduced. Essentially we have atrophy, and if you've got an atrophic nerve, then it doesn't swell. Okay, so they can have it can be difficult. But keep in mind, these are usually the transient vision loss that you get with papilledema. This is going to last maybe a few seconds to a minute at the most, and oftentimes they're going to notice it the most when they're changing posture. So they're laying down, they get up, and they lose vision, and it comes back. Okay, then we're going to start to be thinking about papilledema. Demyelinating optic neuritis can have a totally normal looking appearance. In addition to the unilateral vision loss, one of the things that can help us differentiate this is the pain with eye movements, okay, that they will have. And your suspicion for this should be particularly high in young females. Toxic and nutritional and hereditary optic neuropathies will cause bilateral symmetric vision loss with relatively normal retinas. If you look closely in these patients, you'll oftentimes see temporal pallor, but you also hope that you pick it up before the temporal pallor occurs, because once the pallor has occurred, then you've got permanent vision loss. So before the pallor occurs, the retina is going to look normal. So kind of keep that in your list of differentials, particularly if you have a patient with chronic alcoholism, maybe that they've had bariatric surgery for weight loss or whatever, or some of the medications that we discussed earlier. Compressive optic neuropathy can cause overall pallor of the nerve, but this can be hard to diagnose as well because these patients often don't have severe vision loss. They may only have 20/25 in one eye versus 20/20 in the other eye. And it's easy to just say, oh yeah, that's probably just cataracts or maybe a little bit of epiretinal membrane or something like that. But here again, your most valuable test is going to be a swinging flashlight test looking for a relative afferent pupillary defect. Color vision also will be reduced in patients with a compressive optic neuropathy. Generally, with ischemic episodes, if it's acute, again, you're not going to miss that because you're going to look in and you're going to see that the disc is blurry. But frequently you see these patients years after the fact and they don't know what happened. And so if you have a patient with any pallor for any reason and you don't know the cause, then we need to follow up and figure out what's causing it. Okay, and usually that's going to require some neuroimaging. Once we get back to the chiasm or retrochiasm, then our most helpful tool is going to be visual fields. So the thing about this, remember, is that visual acuity should remain normal if the lesion is behind the chiasm. Okay, they may only call out half of the chart, but they should be getting the letters all the way down to the 2020 or 2015 line if that's the cause of the vision loss. So this is an example of that. This was a 46-year-old Hispanic male, came into our office just for dry, irritated eyes. He had pterygia. He was seeing 2015 in the right. He was seeing 2030 in the left. And we were able to get his old records, which did show that he was able to see 2020 a year prior to our exam. So the decreased acuity led us to do a series of tests. We thought first, he had pterygia, let's see if there's irregular astigmatism. Looked pretty good. Macula looked good in both eyes. Here, our most helpful test ended up being visual fields. Okay, now he had like no light perception off to the side here, and these were all zeros, as you can see. But despite this, remember that the visual acuity in the, I think it was the right eye, doesn't matter, one eye is 2015 and the other eye was 2030. Now the only reason that, okay, it was the left eye of 2030. The only reason that the left eye had 2030 is you can see that the left eye is actually being compressed directly. The optic nerve is being compressed directly by the tumor that this ended up being. So again, keep in mind, you know, he was only down to 2030, but this was critical that we ended up picking this up. He'd only, interestingly enough, we go in there and show him the visual fields afterwards and say, you know, well, you're not seeing on this side of your vision. And he says, oh yeah, I knew that. I haven't been able to see on that side of my vision for 3 months. And I'm like, okay, well, that should have been the reason you came in, first of all, not the dry eye. But second of all, that also gave us an idea of how long this has been going on. This was not there, probably, at least in enough that it would cause significant vision loss 3 months ago. So this is a pretty large tumor that that was very critical that we just didn't ignore. Okay, the decreased acuities. Patients who experience visual field loss that respects the vertical midline should have neuroimaging done to figure out what the cause is. Generally, if it's an occipital lobe, you're going to have isolated vision loss of homonymous hemianopia, versus if it's in the temporal lobe or parietal lobe, then we are going to most commonly have some other issues going on. Maybe they're going to have numbness or weakness on one side of their body, speech issues, or some other sign there. Always keep in mind a transient ischemic attack, also when they're talking about a homonymous hemianopia. And sometimes it can be difficult to diagnose these. This was actually a 27-year-old female that came in a half hour after losing vision on the right side of her the right side. She was also seeing 20/20. This was, again, no light perception off to both sides. Ocular health was normal, and so we sent her for an emergent MRI and MRA, and by the time she got done with these tests, she was actually starting to get some light back on that side. And now when she came back to our office, the visual field had improved significantly. And we followed her for over the next week, and it got better and better and went away. And this ended up being an atypical migraine, okay? So this is a pretty atypical feature, but I like to point it out because it does point out a lot of the things that we should be concerned about with a transient ischemic attack. So a transient ischemic attack generally has negative features, okay, versus a migraine, generally you're seeing lights. This is dark. Transient ischemic attack typically has a sudden onset versus a migraine, which kind of builds up over time. And then generally a transient ischemic attack lasts a shorter time than what a migraine will, generally less than 10 minutes versus a migraine up to 60 minutes. So, but not always obvious in all cases. Sometimes it's not quite so straightforward. You can't have a discussion on unexplained vision loss without at least touching on functional or non-organic vision loss. And this can be quite difficult sometimes differentiating between the two. Start by watching the patient as they're walking down the hall, seeing, you may, if you're suspecting things, kind of put chairs or something that, and watch them so they don't fall, but that they need to navigate through. Watch them and see if they're on their phone out in the waiting room before you call them back. And sometimes that's actually a pretty good indication as well. One test that I find particularly helpful is asking them to bring their 2 index fingers together. Somebody that is totally blind can bring their 2 index fingers together. It's a proprioception task. It's not a visual task. But oftentimes people that have functional vision loss, they'll try to bring their fingers together and they just exaggerate the whole movement and have a very difficult time bringing them together because they assume that they need vision to do that. Putting a mirror in front of the patient can be helpful, and then just moving the mirror slightly. It produces a non-suppressible eye movement as they're following their image in the mirror, and that can be helpful if they're feigning blindness. Stereo acuity is helpful if they have monocular visual field loss. They obviously should not have stereo. And pupillary reactions are probably, again, going to be one of our most helpful tests here, because this is something they can't fake. It's an objective test. Visual field testing can be helpful. Tubular visual fields, you can even test this just with confrontation visual fields. By just doubling the distance between the target and the patient. So the visual field, if you double your distance, should get twice as big. But with functional vision loss, oftentimes you'll see that they have the exact same visual field constriction no matter what distance you do it at. A cloverleaf pattern on an automated visual field test can give you an idea that this is functional vision loss as well. And if the diagnosis is still in question, visual evoked potential can be very helpful. This is a 46-year-old lady with a pretty extensive history. She slipped and hit her head while she was at work 8 years previous to seeing us. And then about 6 months after the injury, she started losing her vision over a 3 to 4 year period. And she came to our office with a white cane and hand motion vision in both eyes. As she was walking down the hall, she used both hands, trying to get down the hall like this. So a little, you've seen blind people, they don't do that, right? A little bit of overacting to start out with. Ocular health was normal. Confrontation visual fields were full to hand motion, and she could see all my facial features equally despite having hand motion acuity. Macular OCT, totally normal. She did have a little bit of thinning superiorly on the nerve fiber layer, the peripapillary nerve fiber layer, but certainly not enough that's going to cause hand motion acuity. The ERG again looks very nice pastel colors, and this is the pattern VEP, visual evoked potential, and this measures the visual pathway all the way from the glasses all the way to the back of the head. So a poor prescription can cause problems. You can have problems with cataracts, optic neuropathies, all the way to an occipital lobe lesion is going to either cause flattening of this curve, or it's going to cause a delay in the curve. And the top graph is at 15 arc minutes, which are pretty small squares. They say you have to have about 20/60 acuity to get that. And at 7 arc minutes, you have to have about a 20/30 acuity. Interestingly, she noticed when we changed target, she said something to us that the target changed. And the luminance does not change. It's the same no matter what you have. So this gave us a pretty good idea that indeed she had functional vision loss, and so that, again, we didn't end up sending her for very expensive testing. So, in summary, dealing with someone with unexplained vision loss include a careful history as well as ophthalmic examination. If necessary, laboratory testing and neuroimaging may be helpful, but use this judiciously to confirm what you're already suspecting. Don't just send them for neuroimaging, just see if there's something wrong. They're not going to find anything. And again, the most important thing, if that you get nothing else out of this, is just not to ignore even small amounts of unexplained vision loss. Keep looking for a cause until we figure out what's going on. Okay, thank you. And here's your